triple-negative breast cancer is a very aggressive disease and accounting for approximately 10 to 20% of the breast cancers worldwide. However, the incidence of TNBC is more in Indian scenario as compared to the Western world, accounting to around 27 to 34%. It can present in a younger age, can present in an elderly population. So the age varies between 22 to 75 years with a median age of around 49 years. So TNBCs, we know that they lack the expression of ER, and HER2 receptors, and the basal-like is the most common molecular subtype or the gene expression analysis that is found in around 80% of TNBC. So apart from the basal-like subtype, there are other unique subtypes which are typical to TNBC. So we are yet to understand their clinical implications. But the other subtypes are the mesenchymal type, the mesenchymal stem like, the immunomodulatory, the luminal androgen receptor, basal-like 1, basal-like 2. So, and the TNBC usually presents as a grade 3 histology, and it's an aggressive tumor, so it may present with the larger tumor at diagnosis and associated with the higher mortality rates and higher rates of distant recurrences. So in advanced stage, the survival remains poor. There is still an unmet medical need. So we have some newer drugs, but in future, hopefully, we'll have some better drugs. So what are the clinical outcome for patients with triple-negative breast cancer as compared to other breast cancers? So just discuss that there is a higher risk of spread outside the breast within the first 5 years after diagnosis. As compared to the other breast cancer subtype, the mean time for distant recurrence is also lower, 2.6 years versus 5 years. 5-year survival is also lower. The median survival for metastatic TNBC is less than 1 year. So despite giving chemotherapy, the patient usually, the disease progresses and the patient usually succumbs. So in this graph, you can see that how the TNBC blue portion is showing a difference with the other breast cancer subtype. However, if a patient is lucky enough to cross the 3 to 4 year mark, then it usually plateaus and the survival is relatively good. But we don't know which patients will cross that 3 to 5 years mark and they will achieve a better survival and achieve that plateau. So as compared to other breast cancer subtype, stage-wise, the survival of TNBC is poor in stage 1, whereas in other breast cancer, the 5-year survival is around 100%. In TNBC is 90%. Similarly, in stage 2, it's 75% as compared to 90%. And in advanced stage 3 and 4, it is 30% as compared to 55%. So the likelihood of distant recurrence is also high in TNBC patient. The rate of distant recurrences can be shown in that graph. A higher proportion of patient recurrent TNBC with a lower mean time to distant recurrence of 2.62 versus 5 years, and a shorter mean time to local recurrence also 2.8 versus 4.2 years. And TNBC we know it is more likely to spread to lungs and brain, and it is relatively less likely to spread in the bone. So there is a huge unmet clinical need because of the higher rate of recurrence, because of the aggressive biology, limited treatment options, survival worse as compared to the other breast cancer subtype. So based on this principle that there is a higher mutation rate of TNBC, which may produce tumor-specific antigens that can induce an immune response. So you can see from this figure that cancer cells, they are characterized by some genetic mutations and poorly functioning cellular regulation. And these result in expression of new antigens that are recognized by the immune system as being foreign, that is being different from the normal healthy tissue. And TNBC, they show a higher mutation rate, which is estimated to be around 13.3 times relative to normal cell. And this may produce new antigens that could induce an immune response, and that could be a potential target to immunotherapy. TNBC have been shown to have a greater amount of T cell infiltration, which is an essential precursor to an anti-tumor immune response. So we know that for an effective immune response, activated effector T cells must travel to the tumor site and also infiltrate the tumor. Primary TNBC tumors show increased levels of tumor infiltrating T cells as compared to the other breast cancer subtype. For each 10% increase in the level of the stromal tumor infiltrating T cells, there is a reduction of risk of around 19%. There is a reduction in risk of distant recurrence of 13 to 18%, and there is a reduction of risk of recurrence of death of around 14%. So the T cell infiltration among TNBC as compared to other breast cancer subtypes. So in this diagram, you can see in the extreme right, the TNBC has around 30% TNBC patients, they have a high tumor T cell infiltration, and around 41% have a medium or intermediate T cell infiltration. So that is much more as compared to the other breast cancer subtype. So based on this principle only, the hypothesis of immunotherapy being active more in TNBC has been tested in the following subsequent trial that I will discuss. So before coming to that trial, so I'll discuss the PD-L1 pathway, which downregulates the anti-cancer immune system. So this is the pathway. So first, there is release of cancer cell antigens. You can see the number one point. Then the antigen, then the cancer antigen presentation is being done, then the priming and activation happen, then traffic of T cells to the tumor, active T cells to the cancer cell happens, and then there is infiltration of T cells into tumors, which cause the recognition of cancer cells by T cells, leading to killing of cancer cells. So at the two steps that the PD-L1 pathway down regulates is the step 3, that is the priming and activation. PD-L1 expression prevents T cell priming and ultimately activation in the lymph node, and PD-L1 expression leads to the inhibition of anti-cancer T cell activity in the tumor microenvironment, which causes killing of the cancer cells. So what's the current manage of TNBC before the approval of Tecentriq? We had very limited options. We still have very limited options, but at least we have one more combination in the treatment of metastatic TNBC. So the first line is either a taxanes or a platinum or combination of platinum and taxane. In the second line, we have capecitabine or the drug that we have not used previously. And in the second or third line, we have option of eribulin, and if the patient is not fit, we have options of best supportive care. So the most active agents are either anthra and taxanes, which can be used either as single or as part of a combination therapy. So we know that combination does not increase the survival, but it will definitely improve the response rates if the patient requires an earlier response, which is associated with more toxicities, and they do not provide any survival advantage. So various factors that we decide are the performance status, the risk of side effects, what is the prior treatment, what is the disease burden, and what's the patient preference. So based on these factors, we decide what's the best possible treatment option for the patient. So this is the graph showing the survival outcomes with the various recommended treatment regimens. So you can see that even with the best possible, all combining all these agents, the survival remains less than 1 year. So very few drugs in metastatic setting have been shown to offer survival benefit in TNBC. These drugs include combination of gem plus cape and eribulin. So they have provided some survival benefit, but still it's not good enough for our patients. So currently, TNBC is a highly aggressive and incurable disease. The mainstay of treatment remains chemotherapy, and it depends what chemotherapy patient has received prior, whether it's taxanes or anthracycline. So now, based on the following hypothesis that I discussed regarding the mechanism of PD-L1 inhibition, so based on this hypothesis, this trial was designed, Impassion 130 trial. So we'll be discussing the results of this trial and probably be confident enough to use this drug in our clinical practice. So it was a phase 3 study. Patients were metastatic or inoperable locally advanced triple negative breast cancer. They did not receive any prior therapy for advanced TNBC. Prior chemotherapy in the curative setting was allowed if the treatment-free interval was more than 12 months. Performance status was 0 to 1. PD-L1 status, all PD-L1 status were taken. So patients were stratified on the basis of PD-L1 status, prior taxane use, and liver mets. So they were randomized into two arms. First arm was the experimental arm was Tecentriq plus chemo of nab-paclitaxel. Tecentriq was given in 840 milligram day 1 and day 15, and nab-paclitaxel was given as standard 100 milligram per meter square day 1, day 8, and day 15 of a 28-day cycle. And the standard arm was nab-paclitaxel, 100 milligram per meter square day 1, day 8, and day 15. The co-primary endpoints were PFS and OS in the intention to treat population and PD-L1 positive populations. The key secondary endpoints were overall response rate and duration of response and safety. So why this drug was chosen and why this regimen was chosen? Because we know that nab-paclitaxel is relatively safe and it does not require steroid medication. So we don't want to expose patient to steroid because we know that steroid may decrease the activity of immunotherapy agent. And we have data to support that both paclitaxel and nab-paclitaxel, they have equal survival in patients with breast cancer. And why 2 weekly dosage was scheduled? Because to fit with the nab-paclitaxel dosage of week 1, week 2, week 3, and followed by a 1 week gap. So that's why instead of the standard 3 weekly dose of 1200 milligram, so a 2 weekly dose of 840 milligram was chosen. So the statistical testing followed a strict hierarchical design. I'll not discuss this slide. So the patients were randomized, around 900 odd patients were randomized in both the arms, around 450 in each arm, and around 40% of the patients in both the groups were PD-L1 positive. So the follow-up period was also very good. So in the experimental arm, the survival follow-up was around 182 patients. And in the other arm, the survival follow-up was around for 166 patients. So coming to the baseline characteristics, they were equally matched in both the groups. In the intention to treat population, in the Atezolizumab plus nab-paclitaxel arm, as compared to the other arm, in the nab-paclitaxel arm, the hazard ratio was 0.80 as compared to the other arm. The PFS was 7.2 months versus 5.5 months. So although there was a benefit of 1.7 months, so but we have an updated data. So even that 1.7 months was statistically significant, and that later translated to an overall survival benefit. So PFS analysis by PD-L1 status. So that is important, that the PFS benefit was more pronounced in patients who had PD-L1 positive. So in PD-L1 positive patients in the experimental arm, you can see that the PFS was 7.5 months as compared to 5 months. In the patients who are not PD-L1 positive, there was not much statistically significant PFS benefit. And the interim overall survival in the intention to treat population showed a 3.7 months numerical difference, although that was not statistically significant in the interim analysis, but still a 3.7 months in a Tnbc patient is good enough. But later in the final analysis, in the latest updated analysis, there is a statistically significant survival benefit. So with the hazard ratio of 0.84, there was a benefit of 21.3 months in the Tecentriq plus chemo arm versus 17.6 months in the standard arm. So by checking with the PD-L1 status, in the PD-L1 status, patients had a survival of 25 months as compared to 15.5 months in the patients who were PD-L1 positive. So there was around 10 months benefit of survival in patients who were PD-L1 positive and those who received Tecentriq plus nab-paclitaxel combination. So comparing to the subgroup analysis based on this forest plot, we can see that in patients who were PD-L1 positive, the benefit was significantly more with a hazard ratio of 0.64 in the combination regimen. Although in patients who had baseline liver mets, there was not much difference in the survival in patients in the experimental and the standard arm. And if the patient had received prior taxane use, then also there was not much difference in the standard versus experimental arm. So the PFS benefit was primarily seen in the patients who were PD-L1 positive, but there was no detrimental effect of Tecentriq in the PD-L1 negative group. So the response rates in the intention to treat population in the experimental arm was close to 56%, and in the PDL1 positive subgroup it was close to around 60%. The response rate in the standard arm was close to 40 to 45%. So coming to the patients who had also BRCA mutation positive, so this is an interesting slide. So few patients were analyzed for BRCA mutation also. So in those patients who were BRCA1 or 2 non-mutated and PDL1 positive, so that patients did exceptionally well with the combination of Tecentriq plus chemo with the hazard ratio in PFS of 0.63, which was statistically significant in survival of and the overall survival hazard ratio of 0.62. In those patients who were BRCA mutated and also PDL1 positive, so in that patients the numbers favored Tecentriq arm as compared to the standard nab-paclitaxel, although it was not statistically significant, but it still favored numerically the immunotherapy arm. So in patients who were BRCA mutated and PDL1 negative, the benefit was not statistically significant in the experimental versus the standard arm. So patients with PDL1 positive tumors derived clinical benefit regardless of BRCA status, although it was more meaningful in those patients who were BRCA non-mutated and PDL1 positive. So now coming to the adverse effects profile. So the adverse effect was not much in the experimental arm as compared to the standard arm. Now we are quite aware of the common toxicities of the immunotherapy drug. So more serious toxicity, they were more or less equally matched, like hepatitis rates were balanced between both the arms. Hypothyroidism was present more in the Tecentriq arm, but it was mostly grade 1 or 2. Pneumonitis was a cause of concern that was present in around 3% of the patients in the Tecentriq arm. Rest of the side effects that they were not very significant and they were almost equally matched. So any grade toxicity of around 57% was seen in the experimental arm versus 42% in the standard nab-paclitaxel arm. Grade 3-4 toxicity were around 8% in the experimental arm versus 4% in the nab-paclitaxel arm. The other side effects, diarrhea, anemia, headache, they were all almost equally matched between the two groups, including the grade 3 and 4 toxicity. So the only toxicity that you should be concerned about is pneumonitis. That also is quite low in the experimental arm. So again, this graph this table is showing that the side effect, the adverse effects were occurring in greater than 1% of the patients in either arm, regardless of attribution. In the Tecentriq plus nab-paclitaxel, so pneumonia, any grade were present in around 10 patients, that is around 2% patients, and grade 3-4 were also present in around 8 patients. And in the placebo arm, there were no grade 3-4 pneumonia. Rest of the side effects were more or less similarly matched. So a higher proportion of patients in the experimental arm had reported side effect 23% versus 18%. No side effect were reported that had a greater than 2% difference between the treatment arms. So only pneumonia, I think, is a cause of concern. So coming to the updated efficacy and safety results, this was the second interim analysis. So that was presented at ASCO 2019 meeting. So this presented the updated overall survival results. So the survival results became more meaningful in these analyses. So with a hazard ratio of 0.86, they favored the Tecentriq arm of 21 months as compared to 18.7 months. And it was definitely much more significant in those patients who were PDL1 positive, around 0.71 hazard ratio and a survival of 25 versus 19.7 months. The updated safety analysis showed a similar consistent result that was discussed previously. Side effects, the serious side effects profile was slightly more in the Tecentriq arm, around 22 to 23% as compared to around 18% in the standard nab-paclitaxel arm. Otherwise, more or less grade 1-2 side effects were more or less similar. There was slightly higher incidence of grade 3 adverse effects in the experimental arm, but most of the side effects were manageable. So IM Passion 130 is the first phase 3 study to demonstrate a benefit with cancer immunotherapy in the metastatic triple negative breast cancer. The benefit risk profile of Tecentriq plus nab-paclitaxel supports a change in practice in first line treatment of metastatic TNBC, especially with PDL1 more than 1 plus in tumor infiltrating cells. So the PFS of was with a hazard ratio of 0.8 in the intention to treat population and with a hazard ratio of 0.62 in PDL1 positive patients, with a clinically meaningful survival of 25 months in PDL1 positive population with more or less manageable side effect profile. So biomarker testing should be a standard at the time of diagnosis in metastatic TNBC, especially to enable patients to be eligible for these newer treatment options. So this is the algorithm that I've taken from ESMO Open, one of the recent review of TNBC. So it shows that when once a patient is diagnosed with metastatic TNBC, so it's important that we do a PDL1 testing and a BRCA mutation testing if it's possible. So if the patient is PDL1 positive, then the treatment option is nab-paclitaxel plus Tecentriq. If the patient is BRCA mutation, then there is option of chemotherapy or PARP inhibitors. So there is not much difference in the PFS in both these treatments. So either of these can be chosen. And if the patient is both PDL1 negative and BRCA wild type, then the option remains clinical trial or the chemotherapy, standard chemotherapy. So to summarize, there is a high incidence of TNBC in India. TNBC is associated with the higher relapse rates and overall poor prognosis. Treatment options are particularly limited. There are no new adverse effects were reported in this trial. A meaningful benefit of 25 months was seen in PDL1 positive patients, and it's one of the first study to demonstrate benefit of cancer immunotherapy in metastatic TNBC. So I think there are other trials coming up which are evaluating the other, apart from nab-paclitaxel, different chemotherapy arm in combination with Tecentriq. So I would be more than happy if that result also turns out to be positive, that instead of nab-paclitaxel, we can use the physician choice of chemotherapy to Tecentriq and provide a meaningful clinical benefit to patients of metastatic TNBC. So with this, I would like to conclude my presentation. And I would like to say that Tecentriq plus nab-paclitaxel has also been approved by DCGI. So it can be used for our patients, and it is also updated in the latest NCCN, ESMO, and AGO guidelines. So thank you for listening to my presentation.